guideline document. It is a guideline document. It doesn't mean that you have to do it this way for every single patient, but it gives you a general scope where to go. And I think the guideline provide this sort of general advice where coronary CTA perhaps should be preferred for patients that have no prior history of coronary disease. So it's mostly for patients where we don't know the state of coronary artery tree or prior sort of events, patients that didn't have prior events. It is recommended for patients at a moderate risk, probably in the sort of a lower part of the moderate risk based on the clinical presentation, although it doesn't exclude the higher risk as well, but perhaps there. Patients that are younger, the guideline use the age cut of 65. But as I said, this is not a hard cutoff point. Certainly, there are some older patients that would benefit from CT. But again, patients that is 50s, early 60s, that's really the population that we also had seen in the clinical trials. So it reflects the clinical trials data. And then the very, very important is, which I really use a lot in my practice, is when I have the clinical question of, does this patient have not only obstructive coronary artery disease, but also does the patient have coronary atherosclerosis? Does this patient have a plaque? I think that's a very important question, is that, as Michael pointed it out, I think even primary care, family care physicians are asking more and more. And it is as critical as we have now growing armamentarium of preventive therapies to actually change the fate of patients that have coronary atherosclerosis. We are in clinical medicine far beyond the practice where we detect obstructive coronary disease. We are in practice, every one of us is in practice of preventing events happening and preventing atherosclerosis. And I would submit that we are actually on the brink of reversing atherosclerosis. And in order to reverse atherosclerosis and fundamentally change the fate of our patients, we need to know how much and what type of atherosclerosis that a patient has. And the coronary CTA is the only test that provides it. Now, with that, I would say there are certainly areas where stress testing has a role. I think I would more use it in patients that have known coronary disease when my clinical question is, does this patient have atherosclerosis? And can I reproduce the symptoms of the patient with the test? And the stress testing is really very helpful for that type of patient. If you're trying to reproduce that your angina, your shortness of breath is indeed introduced by physical activity exercise, and therefore it will guide you as to how to alleviate the symptoms of the patient with potentially revascularization or medical therapies. I think that's where the strength of functional imaging, whether it's with nuclear or echocardiography stress testing is. So that would be my general guide.
Can I make a quick comment? Great. Simply because I'm in that age group and I'm a woman. I would also argue, we talk a lot about, calcified plaque in other areas, but, if we look at our younger female patients where that certainly doesn't work, and coronary CTA is the means to look at the non-calcified plaque, which those will have. And as Mara said so eloquently, those are the ones that we can treat and we can reverse and we can improve their overall quality of life probably and their life expectancy, because by reducing the plaque that we're not otherwise seeing. And they may be, they may have vague symptoms, they may have atypical symptoms, as women often have, and only coronary CTA will show us that. And I think that is an often overlooked and underestimated potential of coronary CTA to serve actually younger female better.